bác sĩ Sonia Solomon nói về cái bài này thì bác sĩ Sonia Solomon là bác sĩ chuyên về thận nhi thuộc trường Đại học Y khoa của New York, và cô đang công tác ở tại bệnh viện Nhi Maria Fahrenheit Westchester Medical Center ở New York. Cái bài bữa nay cô sẽ bắt đầu cái bài về cái điều trị thay thế thận ở trẻ em. Dr. Sonia, you can start your lecture now.
Okay. Thank you everyone for having me. I'm Dr. Solomon, and we're going to talk about renal replacement therapies in pediatric patients. Mostly it will be a brief overview of dialysis and a little bit of transplant. We'll talk in brief about principles of dialysis, indications for renal replacement therapy, the three types, PD, which is peritoneal dialysis, HD, which is hemodialysis, CRRT, which is continuous renal replacement therapy, and about transplant. So when we talk about dialysis, we talk about what are the criteria for someone needing what we call renal replacement therapy. And that, could be dialysis or it can even be transplantation. And so this is in the mnemonic we learn in medical school when we train to say who actually needs dialysis. It's AEIOU. A stands for acidosis. So we always tell families and trainees if it's acidosis that we cannot medically manage, then we will consider some sort of renal replacement therapy. Any significant electrolyte derangements, which includes hyperkalemia, metabolic acidosis, like we mentioned, hypocalcemia, and hyperphosphatemia. The other reason we do dialysis, mostly dialysis, is intoxication. So different medications that either people have intentionally or unintentionally overdosed on. So the common one we see here can be lithium. Sometimes we've also dialyzed for other medications like metformin, but that's one of the reasons we end up doing dialysis. Then we have fluid overload, which is a big reason that people end up doing acute renal replacement therapy on patients. And then uremia. And so this is something when we have patients either with acute kidney injury or chronic kidney disease, if they have uremia and if they're symptomatic, then we'll consider doing some degree of renal replacement therapy. As we go through the lecture, we'll talk about different modalities for this, and we'll talk about acute versus chronic. Some of the other reasons that we think about doing dialysis include someone with persistent hypertension or fluid overload, like we just mentioned. And with our chronic kids, when we talk about dialysis, we talk about decline in their well-being, or if they're very uremic and they're constantly vomiting and not growing, we'll talk about doing dialysis for that as well. A lot of times we'll find if a patient is fluid overloaded, often we will hold their nutrition. And so one of the reasons for starting dialysis is to say now we can sort of give them the nutrition they need, which in a patient who is sick or not well, their nutrition is really important. They can also get neurologic dysfunction or pleuritis or pericarditis from the renal failure. An example of that is secondary to uremia, which can also happen with any sort of bleeding diathesis. So these are the reasons when we think about having patients who have some degree of renal dysfunction, whether that be acute or chronic, heading towards end-stage renal disease. These are the things that we think about when we discuss whether or not patient needs dialysis. So there's two big concepts of dialysis when we talk about it. So we talk about diffusion and convection / ultrafiltration. So diffusion is when you have an area where there's a high concentration of one thing, and you compare it to an area where there's low concentration. This is something that we all know from chemistry, but this is one of the main concepts of dialysis. So if you have a patient who is hyperkalemic, has high potassium, you're going to do dialysis with low potassium bags. And so just by diffusion and by physics, the potassium will move from the high area to the low area. And so this is one of the main concepts of dialysis in general. The second concept is convection. Convection is when you think about this system here, it's a closed system, and you have a pressure gradient that is created. So if we create pressure into one chamber in this closed system, the molecules and fluid will go to the path of least resistance. And so what we mean by that is that you'll have some of these little particles, which we are calling some of the solvent or solutes, they will also move to the area of low resistance. And that will also have, you also have pressure, fluid that removes as well. So that's when you think about convection and ultrafiltration. And those are the two main concepts, even when we think about the three different types of dialysis that we are working with to create an clearance, which is clearing the blood of whether that BUN be high, the potassium be high. If it's a molecular clearance, you're able to do that with diffusion. And then if you're looking for fluid removal, we're going to be using more of the principle of convection. So this is, when I talk about this to other providers, these are the three main types of dialysis that we use at this moment. We have peritoneal dialysis, we have hemodialysis, and we have continuous renal replacement therapy. We'll go into these in detail and talk about when to use each one, but these are the three main dialysis that we'll be talking about today. So when we talk about dialysis and peritoneal dialysis, there can either be acute or chronic peritoneal dialysis. This is our machine, probably older, is a newer one that exists, but a lot of patients and hospitals still have this machine. This is the chronic peritoneal dialysis machine that we use for our patients. Most of the time when we use this machine, it's for chronic. Acute patients will use manual PD, where it is manual, the nurses will manually enter fluid through a catheter, PD catheter, into the abdomen. It will sit there and then it will drain. So we'll talk about the contraindications for each one. So the absolute contraindications are, so you can never get at that moment peritoneal dialysis, are patients with an emphyseal gastroschisis, bladder exstrophy, diaphragmatic hernia, peritoneal membrane failure, or an obliterated peritoneal cavity. So anything really that is sort of infiltrating the peritoneum is a reason that we cannot do peritoneal dialysis. Relative contraindications, including anyone who's going to need abdominal surgery for the same reason that you're worried about breaking the peritoneum, and that all of that makes PD less effective. The other thing you think about is the presence of ileostomies and colostomies. Any significant organomegaly. So our patients who either have hepatomegaly or splenomegaly, the reason for that is just that there's not enough space for a patient to then get volume into the abdomen for it to sit there and act like the dialysis fluid for diffusion. In the other reasons sometimes that we are unable to do peritoneal dialysis, even acute peritoneal dialysis, are patients who are on certain ventilator settings. So on a patient who's on high frequency ventilator settings, doing peritoneal dialysis would not be as effective, mostly because the patient, the way that the ventilator works, it's moving the patient constantly. So there's less room for the fluid to sit there and allow for dialysis to happen. When we talk about chronic peritoneal dialysis, we talk about, one is the medical aspect of it, two is the home aspect of it. So can our patients, if we send them home, is it possible for them, are they suitable to be adequate caregivers? So are they able to properly and sterilely hook up the patient to dialysis? And then what does their home situation look like? Are they crowded? Because there's always a risk of infection if you're on peritoneal dialysis. So you usually can only have one or two other people in the same room that you're sleeping with, most one. Sometimes other patients their kids may have, one other person with them. Otherwise, they can sleep by themselves. The other thing we have to watch out for in chronic peritoneal dialysis is that you need enough space for all of the supplies. So these are things that we think about when we're talking about chronic peritoneal dialysis. So when we think about dialysis, we're using the stomach as the peritoneum, the peritoneal cavity, as your dialysis membrane. So when you think about any kind of dialysis, there's a dialysis filter, and in this case, the peritoneum is acting like the filter. There's dialysis fluid, and there's our blood. And so here with the peritoneum, this is really our filter. We insert fluid into this, which acts as our dialysate. And then our blood, at this point, you'll have fluid in here, you'll have your blood flow here. And so it's able to have diffusion. So with peritoneal dialysis, you'll see that we can manipulate the potassium and the calcium. And there's not much other electrolytes, a few other electrolytes, but not much to help with dialysis. And so the clearance, how we clear the blood, is through diffusion with the dialysis bags. The convection part of it is a little bit different than when we talk about hemodialysis or the continuous dialysis. The convection part of this is based off of glucose concentration. And so the higher the glucose concentration, the more water the glucose is able to pull out from the blood vessels and from the blood to then create ultrafiltration. And that's how you get your fluid removal in these patients. So here we see, you see the capillary endothelium, you have small pores and large pores, and then you have the aquaporins. And so in the small pores of the peritoneal membrane, you have small solutes that are moving through. So that includes your urea, your creatinine, your sodium, your potassium. And then you have large pores, and these are where your larger molecules are moving through. So like your albumin and your beta-2 microalbumin. So when we talk about access, there's either acute peritoneal dialysis or chronic peritoneal dialysis. Acute peritoneal dialysis, here a lot of times when we do it, it's mostly because we have our cardiac babies who've come back from cardiac surgery, who the surgeons have thought, are at high risk for acute kidney injury. And so they'll put a non-tunneled or non-cuffed peritoneal dialysis catheter in. Most of the times when we do acute peritoneal dialysis, it's mostly for fluid. Because if we have patients who have high potassiums or high BUNs, the rate of how fast we can bring that down is much slower because we have less control over certain settings. And so those are the times we do acute. It's usually if there's a cardiac baby, or if there's no other way to do any of the other dialysis modalities, then we'll consider acute PD. One of the other group of patients that get acute peritoneal dialysis is sometimes our neonatal babies, like our NICU babies or any small babies. And the reason for that is because the access in terms of vascular access for hemodialysis or continuous renal replacement therapy is actually much more complicated. And so the peritoneal dialysis in those babies are sometimes a better option. That's acute PD. When we talk about chronic PD, those are the kids that we think will do best at home with peritoneal dialysis. For us, we think that ideally all patients are on peritoneal dialysis. It helps the quality of life. Patients can go to work, they can go to school, and they can disconnect themselves, and they can, feel better with it. And also allows for a little bit more luxury in terms of how much fluid they can drink. Not that we tell them to go overboard, but if you're getting dialysis every day at home versus doing it a couple of times a week, then you're able to, you can probably drink a little bit more. The other thing we talk about with chronic PD, especially in our babies, is that babies are usually getting formula, and formula has a lot of volume. And so doing peritoneal dialysis every day gives us some more leeway in terms of how much volume that they can actually intake. So that leads me to access. So when we talk about access and we need a PD catheter, we talk with our pediatric surgeons. And if it's a chronic PD, this is what we're looking at. It's either curled or straight. You're looking to see how many cuffs there are, and you want the cuffs to be under the skin. So one's in the peritoneum, one's in the subcutaneous tissue, and the rest of the catheter comes out. You can either have a swan neck or a straight neck. And really what you want is for this catheter to be at the bottom of the pelvis. If it migrates and it goes up to the liver, or it's moving up top when it's what I would say looks north, it will not work as well. And so that's why you really have to think about the PD catheter. Here we use something called the Scope Collaborative, which is a really they have put out pediatric guidelines for peritoneal dialysis, including access. And so what they recommend is a Tenkoff curled catheter when we talk about peritoneal dialysis. So when we talk about these kids moving forward, the things that they look at, the surgeons, is one, you want to monitor for constipation. Patients who are constipated, it affects the flow of dialysis. And so we usually, if they come in with abdominal pain or even before, and we see that they're constipated, we'll try to recommend other medications to clean them out before they get a PD catheter. The other thing you want to look for is hernias. Because of the fact that we're instilling a lot of fluid into an abdomen and letting it sit there, it can predispose them to getting umbilical hernias. And so you want to look at that pre-PD catheter placement. Sometimes the surgeons can fix the hernias while they're putting in the PD catheter. So we also have to decide with the surgeons where the PD catheter will come out from. So you want it outside the diaper area for the infants, or the opposite side of abdomen for any stomas if we think that the patient is still, because that's considered a relative contraindication. So if they need it, we want to make sure it's on the opposite side. Before they go in, you want to give them antibiotics the day of the placement because you want to decrease the risk of getting infections. And the omentectomy is a big thing because if they're able to do an omentectomy, so the omentum sits next to the peritoneum. If you're able to do that, then it can help prevent the catheter from being clogged by the omentum. And so it decreases the risk of them having to go back in and fixing the peritoneal catheters. So after they get the catheter, you think about they need a non-occlusive dressing that's changed once per week until the exit site is healed. They still need flushing of the catheters to prevent any blood or fibrin building up in it, because then that can also include the efficacy of the catheter. And then the big question always becomes timing of the catheter when you can actually use it. So based off these scope guidelines, they recommend waiting 2 weeks to prevent any leakage of PD fluid from the catheter. And so in acute situations, you can go ahead and use the catheter. You just have to be mindful that these catheters may leak and that you are limited by how much fluid you can put in terms of your fill volume and how much volume goes into the belly. So after they get peritoneal dialysis, they, like any other procedure, you're watching for other complications. So the big things we worry about is obstruction of the catheter with the omentum. And so really you're looking to see if they have any problems with their dialysis, which means, either with inflow or outflow. The other thing, if you're worried that they're not dialyzing well or they're not removing fluid well, then you can see, did the catheter move? So a lot of times one of the steps we'll start with, if there's any pain or we're worried about flow, drainage or flow from the PD catheter, is an abdominal x-ray to see where the position of the catheter is. So we really want it in the pelvis, but if it moves up towards the liver or anywhere else, then you're going to say, that the catheter needs to be revised at that point. The other complication you can sometimes see is that the peritoneal dialysis catheter will have clots or fibrin. And so this gets a little bit tricky, but in the past, we've put in some TPA into the PD catheter and let it sit there to help break up those clots and see if we can salvage the line. The other things that we can see, one is hernias, which we talked about. You can also see genital edema, and you worry about the pericatheter leak. The two things which are rare but can also happen, one is encapsulating peritoneal sclerosis. And so this is essentially, the way I think about it is when the peritoneum starts to wrap upon itself. If this is untreated, it can cause a lot of complications and even sometimes death in the patient. The risk factors for these patients getting this usually is if you're on peritoneal dialysis for multiple years. I believe it's around like 10 years. And there are certain medications that put you at higher risk for it. So some beta blockers can put you at higher risk. Sometimes even tacrolimus can put you at higher risk. So this can even happen if this develops to you while you have peritoneal dialysis. It can also happen to you even post-transplant. So the main treatment for this, if it's caught early enough, is steroids. Sometimes these patients will present with ascites, And usually if you're able to tap the abdomen to remove the ascites, it will be bloody. Hydrothorax is another complication of peritoneal dialysis. That is when the fluid enters, there's a hole or connection between the peritoneum and the lungs, and the fluid then is moving from the peritoneum to the lungs. Okay, so that's peritoneal dialysis. You know, when we think about that, usually we're having fluid that's instilled into the abdomen. We are able to control the glucose concentration and the calcium concentrations. We decide how many hours we want to do it. If it's at home or for, you know, it's usually around 12 hours, sometimes longer, sometimes shorter, depending on how the patient is doing. And then it sits there for an X amount of time that we can calculate, and then we let the fluid drain and we see how much of that fluid is removed, and we're able to look at clearance by blood work. And then ultrafiltration we see every day based on how much fluid is removed. So that's one type of dialysis. The second is hemodialysis, and this is a dialysis that involves a machine that looks like this, and we'll talk a little bit about it in detail. So the components of a hemodialysis circuit, one, there's the blood circuit, which is where the patient's blood is entering. So usually through tubing, it goes to a pump, and then it goes through the air leak monitors and the trap, and then it goes back to the patient. This is why we worry about anticoagulation if your patient is having low blood flows. And so that is usually a lot of times our babies, because they can only tolerate a certain blood flow. And so in those patients, we always worry about clotting and giving anticoagulation. The second part is the dialysis. You have blood in one part of the circuit, dialysis goes in the other part of the circuit. It is part of the dialysate pump. You have to heat it as well. And then it also helps with the UF, so the ultrafiltration system plays a role with the dialysis. So that goes into the convection component that we talked about before. And then you have the dialyzer, which acts as your filter to help. You have your blood going one way, your dialysis going another way through the filter, and that's where you get the diffusion and also the convection. So here you see, this is our patient. This looks like a fistula, but you see the blood is removed. It goes through the arterial pressure monitor, it goes through the pump, goes into the circuit. You're seeing that this patient is getting anticoagulated with heparin, and then it goes into the dialyzer filter. You see here that you have this is where the diffusion happens. You'll have the dialysis fluid also go into here. You see there can be mixing, which is diffusion. In terms of ultrafiltration, this is where the convection happens, where when we are able to put in the numbers into the machine, you'll see pressure gradients. And then it comes out and goes, there's a venous pressure monitor. They're making sure there's no air in the blood that's returning to the patient. And so this is the clean blood that is returned to the patient. So how do we know if our dialysis is working? So in hemodialysis, we use the urea reduction ratio. So we use the BUN pre-dialysis to the BUN after dialysis divided by BUN after dialysis times 100. And so what we're looking for is a minimum URR of 70%. That's one way we can do. So any patient that we're initially starting on dialysis, we'll do a pre and a post blood work to see what the numbers are. The second thing we look at is K2/V, which is the clearance. And so this becomes more, it's a value that's based off of different laws and volume, but this is usually, we're also looking at BUN. The minimum recommended K2/V in pediatrics is 1.2 for patients who get chronic hemodialysis, which is performed 3 times a week. And so this is really, when we talk about whether or not we're doing adequate dialysis in our patients, we use K2/V and we use their fluid status, and we also look at in hemodialysis urea reduction ratios to say, hey, is what we're doing good enough for the patient? If it's not, then we can adjust your blood flow rate, your dialysis flow rate, your tubing, to say, how can I improve their clearance? And those are the things that you really can modify to change that. So when you have hemodialysis, you also have complications. And so one of the things you worry about in these patients is in initial hemodialysis, when you have a high BUN, you're worried about removing the BUN too fast, and we call it disequilibrium syndrome. And so with disequilibrium syndrome, the biggest sign that we see is either headaches or seizures. And so the reason that can happen is because the BUNs, if it's a very high number, it has equilibrated in their brain. And so to remove it too fast, you get shifts in the osmoles, which similar to sodium can cause various shifts and cause seizures. The other thing we worry about is interdialytic hypotension. So as you remove fluid, do they get hypotensive? But in that case, we can't remove any more fluid. And sometimes we have to give fluid back, or we try to hold the amount of fluid we're removing and see if that works. Other side effects include cramping or nausea or vomiting in these patients, or chest pain. All of these are signs that we're removing too much fluid and the blood volume. And to these patients, what they're seeing is sort of the cramping that you normally see. You get like a Charlie horse or you run. It's anaerobic lactic acid buildup that's causing these symptoms. Some patients also get some itching based off of the dialysis, but you can also have a dialyzer reaction, which is not common. The hemolysis and air embolism also are less common things that can happen, but things that we watch for when patients are started on hemodialysis. So in terms of, we talked about PD access. In terms of hemodialysis access, we think about what type of catheter do they need. So in ideal situations, any patients who are more than 20 kilos, they would actually get a fistula versus getting a hemodialysis catheter. But in order to do that, there needs to be adequate planning ahead of time because these fistulas take a while to work. The benefits in the fistula is that there's lower rates of infection, lower rates of morbidity and mortality, and sometimes their quality of life can be higher. So they can shower, they can swim. So it really does help them in terms of access. However, one of the things we always say is these are the patients that will be on dialysis for a while before getting a transplant, and then we can say we think a fistula would be better for them. So usually it's sometimes older kids, they have to be big enough in order for their vessels to be big enough to be manipulated for the fistula. Patients who are smaller than that will end up getting a central venous catheter that's cupped, so like a tunneled line. And those are for smaller kids. The benefit in that is that, you know, they're easy to remove. They don't have any cosmetic disfiguration. So if you do a fistula in the arm, sometimes it can look bumpy and doesn't look great. And sometimes patients don't necessarily like that. The catheters are painless. When you have the fistulas, you have to cannulate through the skin. So sometimes that's painful for patients. And the other thing that's beneficial to these central catheters are that we can put them in right away. We don't need to wait for them to mature to use them. And so in someone who you need urgent access for dialysis, you're going to be using a catheter versus a fistula. Okay, we're moving on to continuous renal replacement therapy. And so when we talk about patients who need this, what patients are they? These patients are the patients that are hemodynamically unstable. So patients who will not tolerate high blood flow rates that we would usually do on hemodialysis. Patients who need continuous removal for whatever reason. So that could be somebody who has tumor lysis, who is constantly having lysis of the cell and constantly having hyperkalemia. So in those patients, doing 3 hours of dialysis can help bring the number down acutely, but it does not continuously remove it while they are lysing their cells. So those are patients will do continuous dialysis. Sometimes other reasons we'll do it is if you need slower removal of molecules. So sometimes if the BUN is very high, we'll start the RRT to slowly remove it so that they don't get disequilibrium syndrome. The other times that we can do continuous renal replacement therapy is in patients who have certain intoxications. So lithium is a great example, or hyperammonemia, where we use RRT to bring those numbers down until we know that the underlying process has been fixed. So in hyperammonemia, if it's an inborn error of metabolism, we are going to start them on high dose continuous dialysis until we are able to fix the underlying metabolic disease. If it's certain medications like lithium, we can start with high dose dialysis, continuous dialysis, and then wait until all the lithium is essentially leached out of the body because it's protein bound, and we don't have to worry about a rebound effect. So those are the patients that we typically do the continuous dialysis on. These patients are in our intensive care unit because they require frequent monitoring. So when we talk about continuous renal replacement therapy, there's still two big concepts. It's still the convection and the diffusion that we look at. There's various subtypes, which we will talk about in a minute, but we also want to talk about adequacy and how do we know we're doing a good job with our dialysis. In CRRT, we look at the filtration fraction. So this can increase clearance by increasing the ultrafiltration rates, but that can lead to higher filtration fraction. And so this is the formula for it. In most of the modern machines now, this is calculated on the screen. Our goal for filtration fraction is less than 20%. If your filtration fraction is high, you're at risk of clotting, and you might have to either start using anticoagulation or not use it at all, or change your anticoagulation. When we think about CRT, and even any of the other dialysis as well, you think about the size of molecules. So the urea is a small size molecule along with creatinine, phosphate, potassium. So it should be easier to remove. Medium sized molecules include albumin, glucose, uric acid, vitamin B12. And the large molecules are these big albumins, myoglobin, and beta 2. And so this is telling us it's harder to remove these molecules compared to these, which is why when certain things are protein bound, we say, is it bound to albumin? Because if it is, it's going to be harder to remove. So when we think about clearance, you can see here that our normal kidney will have pretty good clearance of all of these molecules. However, when you think about clearance in terms of diffusion and convection, with diffusion, you're better with these smaller molecules. Convection is better with these larger molecules. And I'll tell you why this is important in a second. This is why. Because there are 4 different versions of continuous renal replacement therapy. One is SCUF, which is slow continuous ultrafiltration. So when we think about SCUF, when we think about dialysis and the principles of dialysis, you have diffusion and you have convection / ultrafiltration. And so these are the patients that don't need any diffusion. They don't need any clearance in terms of their blood. They're purely fluid overloaded. There are many reasons patients can get fluid overloaded. Sometimes they have a small degree of AKI and they retain a lot of fluid, and they then become fluid overloaded. Some of our cardiac patients who are in heart failure may have fluid overload. So these are the patients that would benefit from ultrafiltration. Then you have continuous veno-venous hemodialysis. So the line that they put in is in a vein. And what we're doing here is just 24 hours dialysis, so 24 hours of diffusion. This is the primary principle of this modality. You can also get ultrafiltration, but it's going to be, so there is some degree of convection, but most of what we're getting here is diffusion. Then you have continuous veno-venous hemofiltration, which this is when you're doing all convection. And this is where you get the pressure gradients and you get the solvent drag along with the fluid removal. Then you have a combination of these two. I'm getting 24-hour hemodialysis, so 24 hours of diffusion, and then 24 hours of convection. And this is the combined modality that we use for CRRT. So going back to this slide, one of the reasons we think about diffusion and convection is if we have large molecules that we are having a hard time clearing, we might consider doing convection. However, most places, the way you pick between the 3 is usually just really based off of what the institution preference is. So whatever people are used to doing, the institution will continue to do, and the nephrologist will as well. Part of the reason for that is to decrease the chance of error. So when I was training as a fellow, we did CVVHD. So it's a mouthful, CVVHDF. Here, where I work now, we do CVVHD. So in theory, there's no big study that says one is better than others. So really, you could do any of these and be effective in your dialysis in terms of your clearance and ultrafiltration. But if you think about it, if you're having a hard time removing larger molecules, you're going to want to do more convection than diffusion. So what are complications of CRRT? Complications include blood loss. And so what do I mean by this? I mean that when we are having a patient on continuous dialysis, if the machine starts to clot and we're unable to, the machine clots, there's blood in the dialysis circuit, and we're not able to give the blood back to the patient, then the patient's going to have some blood loss. So this is something we tell the families about. There are always risks of thrombosis, just like with any of the other dialysis. You also can have electrolyte or acid base imbalance. The most predominant electrolyte abnormality we will see is hypophosphatemia. Part of the reason for that is because the bags that are made here, they do not have any phosphate in them. And so when you're dialyzing, let's say a patient has a phosphate of 7 and the dialysis bag has a phosphate of 0, you're at a risk of dropping that phosphate, and we have to end up giving them phosphate. If we remove too much fluid, it can cause them to have hypotension, which then creates more issues for the patient. The last thing is with certain CRRT machines and certain filters, you can have bradykinin release syndrome. And so what happens here is that the blood, which is usually acidotic, hits this special membrane and creates a bradykinin release, which then causes hypotension and anaphylactic reaction. When this happens, part of the thing that has to be done is actually not give more fluid, but actually give them epinephrine as treating them like they have anaphylaxis. Usually we see this when there is a blood prime used, because the blood prime is a packed red blood cells that's given to the machine to sort of prime the machine, but that blood can then be sometimes acidic and the pH is low. So now what many institutions do is give bicarbonate to the blood to then make sure that the pH is not so low when it hits the membrane to decrease the risk of this reaction happening. So other complications when you're on CRRT, hypothermia. So the blood is constantly being removed from the patient's body, going back into the patient's body, and unless you have an adequate warmer, the patient usually is cold. There are certain apparatuses that you can put on the tubing of the blood that when it is, so as it goes through the circuit, it's warmed and given back to the patient. However, if you don't have that tubing, sometimes you can put a bare warmer on the patient themselves to help them prevent them from being cold. The other risk is air embolism. So if air gets into the circuit and goes back to the patient, that can definitely lead to issues. You can also have a blood leak where the blood from one side of the filter and the dialysis from the other side of the filter, so there's a break in the system and it causes it to mix. And then the other thing you want to look for is atrial flutter. Sometimes the pump motion can cause an artifact on the screen and give you this atrial flutter while they're on CRRT. So in these patients, when we think about access, usually, we talk to either our intensive care colleagues or we talk to our pediatric surgeons and we say, what kind of line can we put in? So typically we really prefer these double lumen catheters. And based off the size, we sort of predict which size catheter we can use. If they're small and we cannot do peritoneal dialysis for different reasons, and we want to continue hemodialysis or CRT, we can sometimes do 2 single lumen 5 French catheters. I have not done this, but I've heard people doing this in scenarios where the baby really needs dialysis. In pediatrics, or I guess even in adults, we typically do not prefer the femorals because we're always worried that these kids may need transplant later. And so we try to save these vessels for transplant. However, it really depends on the status of the patient. Do they have lines either in their IJ or EJ, and what the intensivist or the surgeon is, what they're comfortable putting in terms of access for our patient. So this is I'm sure other countries have this already, but here it's one of the up and coming machines. This is called a Carpe Diem. And the benefit of this machine is that it can dialyze really small babies. And so right now, a lot of institutions are limited by the size of the babies. So some institutions will say if they're smaller than 3 kilos, it's really hard to do the other continuous renal replacement therapy. So this allows for babies as small as 1.8 kilos to get some sort of continuous renal replacement therapy. So this in some ways is a big game changer for pediatrics and especially our neonatal colleagues, because this is something in the past where if the baby was too small, we could not offer them any degree of renal replacement therapy. This is new here, and there's only 2 institutions right now in New York that have it. And so if there are patients that are that small, sometimes they'll be transferred to those 2 institutions to try to have them on carpe diem. Okay, transplant, which is last but not least. That's really the goal in a lot of these patients. So when you have patients that have the need for renal replacement therapy, we say, is it acute or is it chronic? If it's acute, we'll talk about, do they need continuous renal replacement therapy? Do they need acute hemodialysis, or can they do acute peritoneal dialysis? If these patients do not recover from their acute kidney injury and they end up being chronic kidney disease patients, they can either go home on chronic peritoneal dialysis or chronic hemodialysis, but the goal is to have them transplanted. Other patients will be born with bad kidneys and will have the chronic kidney disease, and we know that they'll need chronic therapy. And so the goal is then for those patients as well to get transplant. Really, one of the things that we've been talking about is trying to get patients to get preemptive transplants. So what does that mean? It means getting a transplant even before the patient sees dialysis. That is the perfect world scenario, that a patient, presents with some degree of chronic kidney disease, progresses, and then before they need dialysis, we're able to do a transplant. A lot of times this is not a possibility because many patients will present with end-stage renal disease. And so those patients, we still have to do the dialysis that we talked about before. There's 2 types of dialysis. There's the deceased donor and the living donor dialysis. And those are 2 options that we give to families. So what are some relative absolute contraindications of transplant? So relative contraindications include any sort of active infection. We say you need to clear the infection. Patients with active TB or untreated latent TB, or HIV, or patients that are relatively at that moment cannot be transplanted. Anybody with active or recent malignancy also cannot be transplanted. They typically, depending on the malignancy, we talk to our oncologist and say, how many years do we need to wait before they can be transplanted? Any uncontrolled site conditions we worry about, mostly because we're worried about adherence and whether or not they're able to take their anti-rejection medicine. If you are non-adherent at the time, a lot of times there'll be a relative contraindication until the adherence can improve. Any substance abuse, you need to be drug-free for 6 months. And the other big thing we think about is your underlying disease. So is that well controlled? So in patients with nephrotic syndromes, what is the albumin? If the albumin is too low, a lot of times we will wait until the albumin is improved by either having them on dialysis, doing medical nephrectomies, or doing true nephrectomies, because the risk of having thrombosis with hypoalbuminemia makes them a non-ideal candidate for transplant at that time. The other thing you want to think about is their underlying disease. So is their lupus under control? Is their ANCA vasculitis under control? And so anyone that requires prednisone for more than 10 milligrams per day, we will consider not doing the dialysis or transplant on, and we'll wait until that's under control. And one of the other things we talk about a lot, especially in our babies, is they have to be at least 10 kilos at the time of transplant before they can get transplanted. So what's the workup that we use? So in our transplant patients, we do the basic CMP, CBC, coags. We also screen them for infectious disease. So the big ones we always want to look for is CMV, EBV, because they can be at high risk for developing these post-transplant. This is common in pediatric because pediatric patients are usually naive to CMV and EBV. Usually adults by the time they're our age or my age, they will have been exposed to CMV and EBV. The other ones you think about is syphilis, toxo, strongyloides, depending on which area of the world you are. And then you want to see, are they vaccinated to certain vaccines? And you want to make sure they don't have HIV or PPD. The reason we check the titers here for these vaccines, MMR, varicella, is because these are vaccines that we give. If they do not develop the immunity to it, then we want to give it to them pre-transplant, because once you are immunosuppressed, you can't get these vaccines because they can be live vaccines. And then you want to say, are these patients at risk of developing blood clots post-transplant? Because if there are, then that's a concern. So then we think about, if they've either had a clot or they have nephrotic syndrome and they're constantly nephrotic, or if they have lupus, these are the blood works you would send to consider to make sure they don't have any other risk factors for forming clots or have a positive hypercoagulable workup. If you have lupus, we check your lupus markers to make sure you are quote unquote in remission. The other thing we think about is imaging. So we look to say, what is their baseline chest x-ray? What's their baseline EKG and echo to make sure we're not missing anything. And then depending on the patient and depending on the surgeon preference, we'll look at the vessels of the patients, whether that be with Dopplers of the pelvis, of the IVC, and a kidney CT. But these are really surgeon preference. The people that need to see these transplant patients before they get transplanted is one, the transplant surgeon, because they have to evaluate the patient, sort of eyeball the patient, say, where would I put that kidney? What size kidney do I want for this patient when they get offers? You also want infectious disease to weigh in, mostly to say what are their risk factors pre-transplant, which then correlates to what their risk factors are post-transplant. And then you're looking at nutrition, pharmacy, financial here in terms of, a lot of these medications are expensive. Do they have insurance? If they don't have insurance, how do we get them insurance? And then we want to say, transplant is a big deal. It requires a lot of stress from the family and a lot of cooperation from the family. So are they ready? Do they have the support that they need? Do they have the financial, not stability, but financial resources they need to be able to take care of this patient? Depending on the underlying renal disease, so if it's a baby born with congenital anomalies of the kidney and urinary tract, those patients might need to see urology to make sure there's no bladder dysfunction before transplant. Cardiac evaluation, usually based off their echo. And then here, just out of insurance reasons, some of them need dental clearance before transplant. So when we talk about the types of transplant, we say, what should patients be getting, deceased donors or living donors? There was this old school of thought that patients who, living donors were ideal and they last a lot longer. There has been a switch since about 2004. Here we see a lot more deceased donors happening than living donors. Part of the reason is that the allocation guidelines here in the US has changed and this put pediatrics on top. And so a lot of family members have then decided that if their kids are not waiting that long, they don't need to undergo the process of being a living donor. And so due to this, we've seen that switch in terms of which kind of donors people are getting. And you can see here, based off on our OPTN data, that, there's more deceased donors than living donors at this point. So, but the thing that we really want to emphasize is the preemptive transplants. They're definitely on the rise. It's more common. So it's easier to do a preemptive transplant with the living donor because then you have a scheduled time for the OR for the patient to go for dialysis versus deceased donors where we're sort of waiting for offers to see if we're able to accept any of them. Okay, intra-op with transplant, the things that so the surgeon is there, he's doing the operation, there's anesthesiologist there, and then sometimes the nephrologist will go in just to see how things are going, but we're obviously not doing the operation. So one, fluid management's a big deal. So we want to make sure that they're well hydrated while they're in the OR to prevent one, hypotension, which then can lead to ATN, but also we want to make sure that their fluids are adequate enough that, or they're not getting too much fluid that causes fluid overload, which then can cause pulmonary edema and require them to be intubated. The other thing we look for is actually hypertension, but also hypotension because it affects the perfusion of the kidneys. Right after they do the vascular anastomosis and you see the kidney quote unquote pink up, which is really cool. And they do the urologic anastomosis, they'll check the renal function to see what the electrolytes are, to see if the creatinine have gotten better. Once they close, they'll always do an ultrasound to make sure there's no thrombosis or any big leak or hematoma after they've done the operation. While they're in the operating room, they are given what we call our induction immunosuppression. So the medication that they get as the donor vessels are being attached to the recipient vessels. And this really is to prevent any massive inflammatory surge that can happen just because you're introducing a foreign object into the patient's body. When we talk about immunosuppression, there's induction, which is a medication you get at the time of the operation, and then maintenance. And one of the things that I think is fascinating about medicine is you can see the progression of what's available today. So in the 60s, there was only steroids and Imuran or azithromycin. Then in the 80s, they formed cyclosporin and we switched to Tacro and Cellcept. And so the main maintenance immunosuppression that patients go home with are Tacro, Cellcept, and plus and minus steroids. But then we also look at your induction. So that's the meds you're getting in the OR. So there's two types. There's the T cell depleting type, which washes away a lot of your big players in your immune system. And there's basiliximab, which is IL-2, which is less immunosuppressive and it only affects IL-2. So all of these affect your T cells and eventually your B cells as well. Which patients get which? And so patients who are born with underlying kidney disease, where we're not worried about recurrence of the underlying disease, we might consider giving them this immunosuppression, which is the IL-2 antagonist. And the part of the reason for that is because when we transplant somebody and we give them immunosuppression, we are worried about their infectious risk factors versus how much we're immunosuppressing them. So I always tell families you're walking a fine line between infection and rejection, and we have to stay on that course. And so in some patients, giving them thymoglobulin increases their risk of infections. And so trying to figure out what's right for each patient is very center dependent. But most people would say if you have a patient who was born with kidney disease and it's a structural abnormality, they would consider giving Stimulect or IL-2. Most other patients who have had another kidney transplant, very sensitized, meaning they have a lot of antibodies, or if they have underlying glomerular disease, they'll get a T cell option. So you can see here, like I mentioned before, most patients now are getting triple immunosuppression, TAC, MMF, and steroids. The other thing that people sometimes do is just TAC and MMF and skip the steroids because steroids can have a lot of side effects like hyperglycemia, hypertension, and it can affect growth and create more obesity. And so for that reason, in our younger patients, if we're able to, we try to take them off steroids. It doesn't always work. And the concern always is about rejection. So having someone on 2 immunosuppression, you worry more about rejection than if you have them on 3. But in our kids, this sometimes is a better option just for their overall quality of life. So what are complications? Complications of this includes, right after they come out of the OR, a urine leak, any sort of ureter seals that form around kidneys, lymphoseals, and then these are probably the big ones we worry about. Do they have any stenosis? So if the urine output drops, if they stop peeing or they become very hypertensive, we worry about are there vessel stenosis or thrombosis, or is there any degree of urinary obstruction with anastomose, the ureter of the donor to the ureter of the recipient or to the bladder? So those are the big things we think about right after they come out of the OR. The other things we think about long-term is, graft dysfunction. So is the kidney working? In the acute setting, you can sometimes get delayed graft function, which means that they need dialysis within the first week of transplant. There are many different risk factors for this. Sometimes it's the cold ischemia time. Sometimes is were they hypotensive in the OR? Sometimes is what was the kidney like even in the donor before it got to the recipient. The big thing we worry about always is rejection. So you can have chronic rejection with acute cellular rejection or antibody-mediated rejection. And these have to be diagnosed with biopsy. If we see these, we then have to treat these. The other thing we worry about is infectious. So, there are at risk of opportunistic infections like CMV, EBV, and BK. And these are things that are monitored. For CMV, we can give them prophylactic valganciclovir depending on their risk. But for EBV and BK, there's not too much prophylaxis we can do. It's really just monitoring. Once these are positive, we say, are they over immunosuppressed? Do I have to decrease my tacrolimus, my Cellcept, my prednisone to help their body to fight these infections? The thing you worry about on the flip side of that is actually rejection. There are medications for CMV that you can use for treatment. Same thing for EBV. BK, there's not much good evidence for many of the options out there, and so really it's decreasing immunosuppression. The other thing we worry about in transplant patients, especially patients who got tacrolimus, is TMA, which is just thrombotic microangiopathy, where you see hemolytic anemia, thrombocytopenia, and AKI. With steroids and tacro, you're at risk of hypotension. It's supposed to say hyperglycemia. And you also worry about recurrence of the underlying disease. So patients with FSGS, we always worry about recurrence. IgA can also have recurrence. Lupus is less likely to recur, but we always worry about this when we think about graft dysfunction. The other things we worry about is cancer. So are they at risk of post-transplant lymphoproliferative disorder, skin cancer, or do they get cancer in the native kidneys? And these are things we watch out for based off their symptoms, screening in terms of like skin cancer, and saying, are there any other markers? And so PTLD, you look for EBV as well. And that was my last slide. I may have spoken kind of fast, but if you guys have any questions, this would be a great time to ask.
Yeah. Thank you, Dr. Solomon, for your lecture on overview about main modality for renal replacement therapy for children with chronic kidney disease. Also, it's time for question and answers. Dr. Solomon, in Vietnam, it's very difficult to perform renal replacement therapy for children, very young children, example for 10 kilogram, because we don't have a special machine for dialysis for such small baby. And for BD, we only have two type of BD catheter, one for adult side and one for children side. And for very young, very little baby, it's very difficult to access the BD catheter. Can you share us about your experience to perform dialysis for such small baby?
So if they are less than 10 kilos, usually our biggest barrier is access. And so can they put in a hemodialysis line or a CRT line is usually our biggest barrier. If they're unable to, for based off the patient, then we try to say, can we do peritoneal dialysis? And really realistically, for me at least, usually that really is limited, I say, by 3 kilos. I feel like when they're smaller than that, it can be really hard to even put a PD catheter in. And so in those patients, usually if they're that small, they're usually in the neonatal intensive care unit. And we run into the same problems about, are we effectively able to put a catheter in? Will it work? If it doesn't work, then we're sort of out of luck in terms of what options we have. Which is why when Carpe Diem came out, everybody got really excited because it's a modality we can use for smaller kids. The downside to Carpe Diem is that it's expensive, and it's a lot of training for the nurses and everyone to do. And so a lot of institutions don't have it yet. The other downside is that a lot of these kids that are that small usually have other comorbidities that causes them to not do well to begin with. And so their outcome, even before having kidney disease, usually is poor anyway. And so then we talk to the family about the risk and benefits of doing certain dialysis. But, for us, I would say less than 10 kilos. But if it's less than 3 kilos, we really have a hard time even doing dialysis in those babies.
Câu hỏi ở đây là bác sĩ Quang hỏi là ở Việt Nam thì đối với những bé mà nó nhỏ quá dưới 10 kg á, thì mình rất là khó để những cái biện pháp thay thế thật vì mình không có cái quả lọc cho trẻ dưới 10 kg. Thì xin cô chia sẻ kinh nghiệm. Thì cô trả lời là nếu mà có những bé nào mà nhỏ dưới 10 kg á, thì nếu như mà không chạy thận được á, thì mình có thể thay thế bằng cái lọc màng bụng. Còn thậm chí là có những bé, thật ra thì ở với bên cô thì những bé mà nhỏ hơn 3 kg thì cũng có gặp khó khăn, cho nên là khi mà có cái máy mình quên tên cái máy đó thì nó sẽ có hỗ cho những bé mà dưới 3 kg, nhưng mà có cái bất lợi là không phải cái cơ sở nào cũng có hết, thì người ta cũng gặp khó khăn như mình. Excuse me, Dr. Sania. How many sides of the catheter for the pediatric PT? For the PT catheter, how many sides do you have for the patient?
How many catheter sizes?
Yes.
I actually don't know the answer to that because we usually rely on our pediatric surgeons. to say what catheters that they want to put in. I don't believe there's that many options, but I could find out and let you know later what sizes that we have here. I'm not sure if Deanne knows what they use at his institution now either.
Do you experience the pre-BD peritonitis at the center?
So,
Because at our center, currently we have 18 patients, but the percentage of peritonitis that happened before we started BD was very high, about 30%.
We do see peritonitis. It's not as common, I would say, but we definitely see it. A lot of times when we see it, our dialysis nurses will say it's based off of technique. And so the SCOPE guidelines, which are guidelines that came out of multi-centers, a lot of institutions will use now to say, how do we prevent like infections and things like that? But we do see it. And a lot of times when we see it, it's usually in our patients who are being dialyzed at home. And it's usually related to some degree of technique when the parents are doing it at home. And we have to sort of retrain them to say, okay, what's the proper way to do it sterilely so you decrease the risk of infection. In the hospital, it's all the nurses that are doing it. So when we have infection, we say, is there something wrong? Is there a break in the system, or there's something wrong in the system? At home, when they go on to do chronic PD, the nurses do this intense training with them. And then based off of that, they then can graduate and do it at home. But when they get infections, they usually say something about the technique that the parents are doing. And they have to get retrained.
But so do you mean that if the patient had a pre-BD peritonitis, is mainly because of the technique, the operation technique?
Not operations, usually hooking them up together. So like on the day-to-day when they get placed on PD, like let's say they do it at night, usually it's the technique of wiping the cap, hooking them up that gives them the risk of peritonitis. It's usually not the surgery itself. It's usually afterwards how the catheter is being taken care of and how they're hooking them up. So here, when they do it, they have to wear gloves, and they have to even before COVID, they always had to wear a mask, and they should only have, if it's an adult, they just have the adult do it themselves. If it's a kid, they have one parent there, and they're wearing the mask appropriately, and then washing their hands and cleaning and hooking them or unhooking them correctly. In babies, one of the things we worry about is the catheter and the diaper. And so if the catheter gets contaminated by stool or urine, mostly stool, it increases your risk of peritonitis as well. And other times it's like, is it on their skin flora? Is that one of the reasons they get, they're colonized with sort of infection? So MRSA is one where some institutions will screen them for MRSA. To say, are they colonized for it? Should we eradicate for it before we end up starting the peritoneal dialysis?
At our center, we keep the patient for 14 days after the operation, the insertion of the catheter cuff. So on 2 weeks after the operation, the nurses, the PD nurses, we take care of the patient, and they they perform the technique, but the infection is still happening. So I just wonder what is wrong with maybe
do they get like prophylactic antibiotics?
Yes, we have the cefazolid before 1 hour before the procedure.
Do they get gentamicin around the catheter, like ointment, gentamicin ointment?
The ointment?
Yeah.
We don't.
That's one of the things I hear. I don't know if that would help. But that's one of the things our dialysis nurses will do here around the catheter too. Around the exit site.
After 1 week after the operation, we change the rest once every week. So we don't apply the cream, the antibiotic cream like mifepristone around the no, we do not apply gentamicin or mifepristone around the exercise. We just change the stress once every week.
Once every week, yeah.
Yeah.
That's what we do too. I mean, those are pretty much the things that we're doing to prevent infection for us. I could look at the scope guidelines to see if there's anything else that they recommend in terms of like preventing peritonitis, but those are the big things that we do with our kids to try to prevent them. Is everyone growing the same bacteria, or is it different bacteria when they have peritonitis?
The cultural negative was 80%. Just one patient have MRSA.
Okay. Yeah, that's a little tricky. I'm not sure exactly why the rates are different. But I could look into the scope guidelines that they've created here to say, is there anything else that we should be doing?
Không biết là các đồng nghiệp còn câu hỏi gì khác cho Dr. Solomon không ạ? Dr. Solomon, so it's too late in America, and at the moment we don't have any question more. So maybe we stop the webinar now. Again, we would like to say our special thanks to you and Dr. Ding sharing with us your busy time on a very interesting lecture.
Thank you for having me. It's always a pleasure.
Thank you again. Bye bye. Good night.
Thank you.
Dr.
Have a good
Solomon,
day.
Dr. Ding. Yes.
Bye.
Bye.